Everyone, today we are going to see a case of malignant melanoma of the heel for which a wide excision, ALT free flap reconstruction, popliteal node dissection, and a minimally invasive ilioinguinal block dissection was done. At presentation, the patient had a large ulceroproliferative growth in the heel for which wide excision with 2 cm margin and a ALT free flap reconstruction which was anastomosed to the posterior tibial vessels. After this, patient underwent a popliteal node dissection. At the end, we can see the sciatic nerve and the posterior tibial vessels completely bare. This is the end block removal of the specimen and closure and drain placement after a popliteal node dissection. Then the patient was positioned supine, and these are the incision markings for video endoscopic inguinal lymph node dissection. The first step is walking over the deep fascia. Now we can see we are walking along the deep fascia over the sartorius muscle laterally and adductor longus muscle medially. So this continues until we reach the inguinal ligament. This is called creating tunnels medial and laterally. You can see the glistening layer of the inguinal ligament laterally. Now this is on the medial side where we expose the inguinal ligament. So two tunnels are created. The basics of creating tunnel is that between these two tunnels, the fibrofatty tissue holds the communication between the superficial saphenous vein and the deep femoral vein. Once the tunnel creation is done, we incise the deep fascia along the adductor longus muscle and the sartorius muscle, exposing the boundaries of the inguinal ligament. Once the boundaries are exposed, now we can release the fibrofatty tissue between these two tunnels and expose the saphenous vein. Now you can see the femoral vein is exposed and the upper border of the femoral vein is dissected so that the communication between the saphenous vein and the saphenofemoral junction is completely exposed so that we are able to ligate the saphenous vein and clip it so that the superficial nodes and the deep nodes are completely separated. Once the saphenous vein is isolated like this, a hemlock clip is placed across the saphenous vein and the saphenous vein is cut. After this cut, the superficial system and the deep systems are completely separated. So we start our dissection of the deep nodes from the apex of the inguinal ligament, leaving the fascia over the iliaca, which covers the femoral nerve. So we walk along the femoral artery, leaving the fascia laterally. Now we after removing the nodes over the femoral artery. Now we shift our focus to remove the nodes along the femoral vein up to the level of the Clockett's nodes, deep nodes up to the femoral ring. So once this deep nodes are removed, the deep node dissection is completed. Now we ligate the saphenous vein distally and release the superficial nodes from the scarpa's fascia. You can see the glistening layer of the scarpa's fascia since we have already separated the entire superficial system from the deep system. The only thing we have to separate is the scarpa's fascia to remove the superficial nodes. There will be few tributaries of the saphenous vein, that is the superficial epigastric, superficial circumflex iliac, and superficial external pudental, which can be managed by the ultrasonic shearers to remove these nodes. As you can see, the superficial system is completely separate from the deep system. Once this is done, the entire specimen is placed in the endo bag and the specimen is extracted via the 10 mm port. After specimen extraction, we place the ports back again and give a complete wash, and under vision, two drains are placed through each 5 mm port, and that's how the closure looks, and that's the specimen of the inguinal block dissection. Then we proceed with the laparoscopic iliac block dissection in the same position. A peritoneal incision is made along the external iliac vessels, which is extended proximally and distally to expose the first structure along the medial leaf of the peritoneum, which is the ureter. Once we identify the ureter, which is one of the important structures in the iliac block dissection, we medialize the structure and completely expose it distally till distally so that it never comes into the field of dissection. All the fiber fatty tissue are lateralized and the ureter is medialized. Once this is done, you can clearly see. Now we turn our attention towards the internal iliac artery, which continues as the obliterated umbilical ligament distally. So the internal iliac artery is completely exposed and all the fibrofatty tissue are lateralized again, and the internal iliac artery is medialized. You can see the posterior branch of the internal iliac vessels there. So it is completely exposed from proximal to distal. Once this is done, a standard pelvic node dissection is began from the external iliac artery, respecting all the boundaries, that is the genitofemoral nerve laterally, the deep circumflex iliac vein distally, and the common iliac proximally. You can see all the nodes from the obturator fossa along with preserving the obturator nerve, and the pubic bone is completely exposed. This is the last step, and the specimen is kept in an endobag and it is extracted via the 10 mm by expanding the 10 mm port, and the ports are closed. Thank you.